Thank you, sir. I'd like to thank our teacher, Lalit Verma, sir, for having me here this morning. Very good morning to all of you. I'll be speaking on Brolucizumab. Where does it stand today, basically? So this is going to be the agenda. Well, the prognosis of retinal vascular diseases has changed following the advent of anti-VEGF, and this is something we know. And what it has done, actually, is there has been a reduction of the blindness due to retinal vascular disease. So today, what are the treatment options that are available? We have off-label bevacizumab, ranibizumab, aflibercept, and of course brolucizumab, which was approved a little while back. Pegaptanib, we don't use it much. So what is brolucizumab? Brolucizumab is one of its kind single-chain fragment antibody with a small molecular weight of 26 kilodaltons. And because of the small molecular size, it is supposed to have deeper penetration into the retina and the choroid, faster onset of action, and greater molar dosing is possible, and also lower systemic concentration. So the approval came through after the Hawk and Harrier trials. And what we see here is that there isn't much difference when it comes to the visual acuity part of it with aflibercept. However, when you look at the anatomical structures, then of course you find that there's a difference. Brolucizumab achieved superior reductions in CST from baseline to week 16 and 48, and this difference was reaffirmed at week 96. Now, a comparison of the therapeutic response between brolucizumab and aflibercept in the Hawk and Harrier trials using deep learning-based OCT analysis showed that there was extensive decrease in IRF following the first dose. There was superior SRF resolution with brolucizumab. And one thing that was noted with aflibercept was the sawtoothing that was not there with brolucizumab. You also had more pronounced PED resolution with brolucizumab. So increased fluid resolution, is it important? Well, if we go back to CAT and I1 and compare it with Hawk and Harrier, we have a similar story. If you have more CST variation, you have poorer vision. So in Hawk and Harrier, in patients that were almost always dry or always dry, you had these patients having lower CSFT variations, and these were the patients who had longer fluid-free intervals, had ultimately better visual acuity gains. Now there has been a lot of talk about the IOI. So there was a safety review committee which classified and looked into the IOIs, and they found 49 cases, of which there were 44 of observations of interest, out of which 14 were IOI alone, 11 with IOI and retinal vasculitis, and 19 with IOI, retinal vasculitis, and retinal vascular occlusion.
And can we come to the topic per se, rather than, what is your impression, what is the role of brolucizumab today? Right. So that, we have a clear answer. This knowledge can be Googled from any time.
So, yes. So we'll move forward. And so basically,
the reason this topic was there, because we are all familiar that IOI and vascular block conclusion is the bottleneck.
Right.
Why it is not getting so much importance.
Right. So basically, inflammation has been found to be there in other anti-VEGFs also, and there has been reports of racial and genetic differences with different anti-VEGFs and other medications. And based on our preliminary results of our studies, what has been seen is that in the Indian context, the number of IOI has been less. Now, the other important thing is that if you look at the Merlin study, which was stopped in between, what actually happened was that in this study, they were evaluating recalcitrant NAMD, and they had 4 weekly injections of brolucizumab and aflibercept. And as you can see, 9.3% was the IOI with brolucizumab and 4.45% with aflibercept. So what it ultimately meant actually was that a 4-weekly regimen with brolucizumab or maybe aflibercept was not necessary. So if you look at the real-world data from the Western world, with the IRIS and the Komodo providing us with the largest set of data, the incidence was 2.4%. Moving on to the Indian experience, according to these publications that we've had, we first published the Braille study where we actually had 94 eyes. This was an initial study. And what we found was that the durability was good. It was 10.2 weeks. And the visual acuity improvement was significant across the full cohort, so also the central subfield thickness. But what was most interesting was that besides the improvement in the fluid characteristics, the only adverse event that we recorded in this series was an RP rip, which we went on to publish, but there was significantly no inflammation in this series. So just to show a case example, this is a naive eye which received Brolucizumab, and as you can see, after one injection, this is 1 week post the injection, the shram started melting up. There was this improvement in the CNVM complex, and this is at 12 weeks after one injection. And we repeated a second injection at this point in time because there was this hemorrhage that came up. And this is after 24 weeks of the second injection. So what happened post the Braille was that the patient was on a 12-weekly regimen, although we followed her up every 4 weeks. And she has, in 1.5 years, received 7 injections. The vision is still good, and there's hardly any fluid now. So we've also experienced Brolucizumab in PCV. Again, it was the same story. Visual acuity improvement was good. It was statistically improvement. A lot of these patients actually went on to gain visual acuity. And actually, again, if you see that the disease activity results from the PCV study, 43% had no disease activity, that is no SRF or IRF at the last follow-up. Again, in this PCV subset, which we had a follow-up of 27, mean follow-up of 27 weeks, again, there was no IOI that was noted. And both of these were multi-center studies. We have little experience with the Brolucizumab in submacular hemorrhage, and we used RTPA with C3F8 gas injection, and it seems to work well. Again, no inflammation. Looking ahead, Brolucizumab in DME, the FDA has approved recently, just a couple of days back, Brolucizumab for DME, and we were part of the KITE study. Again, similar visual acuity improvement. What was interesting here is that 50% or more of these patients could be maintained on a Q12 weekly dosing regimen, which is important in the sense that these patients with diabetic macular edema could actually go on for a longer period of injection-free interval. So if you look at the KITE and Kestrel safety data, so what has happened here is that the KITE is basically this part of the study was mostly done in Asia and had a lot of patients from India also, and we were also part of this. So if you see the IOI rates were 1.7% for both Brolucizumab and aflibercept, as opposed to Kestrel, where it was 4.7% for 3 mg, and 6 mg it was 3.7% compared to aflibercept, 0.5%. So again, there is this question of racial differences or genetic differences being part of the issue. What has been the Indian real-world experience in DME? Well, we've published 2 small series, and we've seen that
we need to summarize, please. Time is not on our side.
Yes, sir.
Yeah.
Yes, sir. So this is the last slide. So basically, it exhibited good visual acuity outcomes lasting up to 16 weeks and good anatomical improvement persisting up to 12 weeks, followed by early recurrence of fluid at 16 weeks. So the decision not to initiate a new drug is heavily influenced by who says what, but the decision to adopt a new drug is clinched by subsequent personal experience. Thank you for your kind attention.
Thank you, DEBDULAL. I am still looking for that answer. Where are we today in Brolucizumab?
So basically, sir, as far as IOI is concerned, so we've used 1100 vials at Disha, and as of now, we have 4 cases of inflammation. And all of these have been managed without vitrectomy. We've used topical and oral steroids. So that's one. And beyond the full Indian data, I'm not aware of how many, but what I hear is around 50 IOIs have been reported across the country, and probably around 10,000–11,000 injections.
Okay, we'll talk about